I am Dr. Jahangir Shah. Sorry. Today we will discuss the acute stroke intervention. So, as we know, the stroke is one of the complication, and any procedure that we are doing in our cath lab, every procedure have a complication, that is stroke. Some patients have a higher risk, some patients are lower risk. So, stroke is an emergency. Stroke is we call as a brain attack. So, occur the definition of a stroke when a blood vessel that carry blood, oxygenated blood or nutrient to the brain, either it's blocked or burst. If it's blocked, it's a ischemic stroke, or if it's burst, it's a hemorrhagic stroke. So, what are the my presentation layout will discuss the types of stroke, prerequisites about the good outcome. We'll discuss about the inventory that is available here in our cath lab. Basic concept about the mechanical thrombectomy. We'll discuss about the guidelines of mechanical thrombectomy, some terminology used in acute stroke intervention, and in the last I will show you few cases that was we have done in ICUD. So stroke is divided into two major parts. It's a ischemic stroke and hemorrhagic stroke. And hemorrhagic stroke is about 15%, and the ischemic stroke is further divided into the large vessel occlusion, cardioembolic, lacunar, or other. So today we will discuss, our focus is large vessel occlusion. So before that, what is large vessel occlusion? Any occlusion that is occur in the internal carotid artery, or in the middle cerebral artery, or in the posterior circulation like a basilar artery or posterior cerebral artery is called the large vessel occlusion. So mechanical thrombectomy is indicated patient having a large vessel occlusion. Before going for anything, you should know how quickly assess the stroke patient. You should be fast by examine the patient. That is the first examination done while patient develop a stroke. You have to check the balance. These are the loss of balance, headache, or any dizziness. These are the posterior circulation of stroke sign. That patient they can present with this. There's a blurred vision, there's facial weakness, patient have a arm or limb weakness, speech difficulty, and time. So in stroke, time is the brain. You have only little window for the intervention. Either you are going for the medical intervention or the mechanical intervention. So this is the very famous NIHS score. So you have to calculate the first interaction with the patient is the NIHS score. That's our postgraduate have to do in the emergency department. So what to do? What are the cortical signs? You have to see the gaze, reflex, visual, and the base language, and the dysarthria, and will assess the motor deficit, the weakness in the arm, limb, and will score. Their maximum score of NIH is 42, minimum is 0. So it's very easy. You have in your mobile, you can just download the app and calculate the NIH score. It's further divided into these grades. Either no stroke, there's a 0 NIH score. The patient having a stroke, that is minor 1 to 4, and the moderate score is 5 to 15. So if any patient who develop a left-sided weakness in the upper arm, your score is 4, and in the lower leg, their score is 4. So that total, if you calculate, is 8 from the weakness. If they're having a difficulty in speaking, so you can add 3 more. So if NIH score is moderate to severe, is indicated for the stroke intervention. This is another score, the aspect score, that is to be calculated for the middle cerebral artery intervention, in which we have to see the ganglionic and preganglionic area. You can see the MCA territory. You have a M1 to M3 segment, and there is the chordate, lentiform nucleus, insula, and the capsule. Normally, the aspect score that is calculated on the CT scan. Normal is the aspect is 10. If patient have a 10 aspect scores, normal. But those which patient they are indication for the mechanical thrombectomy is the aspect score should be 6 or more than 6. So any problem in that, you have to minus 1 from this score. And this is the modified Rankin scale. We just calculate the patient activity. The MRS 0, patient have no symptom, from the non-significant disability in the MRS 1, 2, 3, 4, 5. So the inclusion criteria, a patient having a MRS score less than 2. So the to diagnose the stroke, you should have availability of the CT scan. Although the MRI is the standard, it can detect stroke, acute ischemic stroke within a minute. But some few early ischemic signs you can see on the CT plane. You can see the decreased parenchymal X-ray attention or loss of gray or white matter, their loss of sulci, there's the insular ribbon sign, tissue swelling or any hypodensity. And this is the very dense MCA sign. This is the plain CT scan. You can see there is the thrombus seen in the middle cerebral artery territory that was confirmed after giving dye. After this CT angio, you can see there is a total occlusion of the left MCA. So guideline shows the 6 point is class 1 indication mechanical thrombectomy. If patient has a NIH score is more than 6, aspect score is more than 6, he is in the come within a 6 hour of the history, and patient have a large vessel occlusion. So these patients should be taken for the mechanical thrombectomy. And mechanical thrombectomy stent retrieval is a class 1 indication over the TPA. So these are the class 1 indication for the mechanical thrombectomy. You can see age, pre-stroke, MRS score, NIJ score, aspect score, and the early involvement, the large vessel involvement, and the time to groin puncture is less than 6 hours. So now come to the management. What are the options you have available for the stroke intervention? If patient present within the window, because you have two options, either you will go with the intravascular TPA or mechanical thrombectomy. When you say the intravascular TPA was started in 1994 or 95, but the window is very small. Initially it was 3 hours, later on it may extend up to the 4.5 hours. If patient, most of the patients, they lost this window at the present late. But the main thing is that the mechanical thrombectomy. Before going to the mechanical thrombectomy, the intravenous TPA revascularization rate is very low. It's about 8 to 32% of the patient. The recanalization you can see. If the high thrombus burden, the recanalization rate is less than 9%, and the reocclusion rate is also high. So the TPA was compared with the mechanical thrombectomy. Initially, the mechanical thrombectomy was done within the 6 hours of the symptoms. Later on, I will show you some trial that shows the mechanical thrombectomy, how it will indicate what is the time. It's first of all, when it was started in 2015, the window period was 6 hours. Later, the Dawn and Diffuse trial, they show it can be extended up to the 24 hours after doing some CT perfusion scan and all. So, if you want to do the mechanical thrombectomy, you should know the anatomy of the vessels. So, first of all, you should come into the internal carotid artery. Internal carotid artery have 4 parts. One is the cervical part, that is the straight part. And another you can see having a sphenoidal part, cavernous part, and intracerebral part. This is the terminus. So these 4 parts you remember, you have to place your catheter at these areas when you are doing. And the angiographical view, they are simple epicranial, lateral, left lateral, Townes view you can clearly see. And we do angiogram on the DSA. So you should know the mechanism of penumbra. Whenever any cerebral artery occluded, this is the core area, this is the dead area. You can't do anything for this area, but the penumbra is very important. This is the area under thread. So we have to take care of this area. Whenever the artery is totally occluded, collateral flow that prevent the rapid damage of this area. So the penumbra is very important for this stroke intervention. These are the algorithm. I don't want to go in this algorithm. You have a window within 4.5 hours. You could give TPA or you could bridge with mechanical thrombectomy. There is also a perfusion scan. You can say assess if there is a mismatch ratio is more than 1.8 or mismatch volume is more than 15. You can go for the mechanical thrombectomy if patient present late after 6 hours within 24 hours. So this is the concept of penumbra. So initially the mechanical thrombectomy was started from 1999. They have tried till 2030. There was no any benefit seen while doing mechanical thrombectomy. But later on, in 2015, these are the trials: Mr. Clean, SCAP, Extend, IA, and Swift Prime, Revascade. They have shown there is a remarkable change in stroke, and the stroke, there are positive trial that they have data that mechanical thrombectomy is better than this. So how is thrombectomy done? For thrombectomy, for thrombectomy, what are the access site? You have a femoral access option, you have a brachial access option. Some condition even you can use the transcarotid access site. So you have to just pass a sheet to do the diagnostic angiogram to confirm or finding. Most of the finding will CT scan and CT angio will show us the finding. So then we have to see there are three techniques used in mechanical thrombectomy: stent, retrieval only, adopt, or Solumbra technique. So you should know the inventory before the doing mechanical thrombectomy. What are the diagnostic catheter we use? Mostly the SIMS catheter, SIM1 and SIM2, head hunter catheter. We can do the diagnostic angiogram with the help of JR, multipurpose. This depends upon the arch. And another thing is the destination sheet. This is the sheet available in our store, is the Cordis, Fubuki. We have a Termo sheet. You have a balloon guide catheter, and we also having a shuttle sheet option for the destination sheet. Guide wire, the Texas wire is available. The special dedicated wires, 200 centimeter. But we are using coronary wires, cheaper than these cerebral wires. You have a micro catheter, there's a Rebar and other, and this distal access catheter, also called as the aspiration catheter. We have option of Sophia Plus, and we have a React, Navian. These are the three different type of aspiration catheter. And in the end, we have a stent retrieval, that is the Solitaire or Eric. So while doing the mechanical thrombectomy, you should know the tower, mechanical thrombectomy tower. After confirming your finding on the angiogram, you just take a guide catheter, that either balloon guide or extension guide catheter, the Termo sheet, anything. You just take guide catheter. Over the guide catheter, you have a aspiration catheter. This is distal access catheter, micro catheter, and the wire. You just have to cross the thrombus with the wire, guide wire, and with the support of these all micro catheter and aspiration catheter, distal aspiration, and the guide catheter. So this is how we make a tower. So we already discussed there are three techniques. Mostly the aspiration technique, also we called as the adopt, in which we just cross the thrombus with the help of wire and micro catheter. We advance our aspiration catheter, that is either Sophia and all, and then just grab the thrombus and come out without using stent retrieval. This is called adopt technique. If you have used the stent along with distal access catheter, this is called Solumbra. We are just grabbing the thrombus with the help of stent and aspiration the thrombus with the help of distal aspiration catheter. This is called Solumbra. Somehow you have a difficulty to track your aspiration catheter up to the M1 segment. At that time you can use only stent retrieval technique in some cases. So this is the Solumbra system. We already discussed. This is Solumbra system is already discussed in detail. So what you want to achieve while you are doing mechanical thrombectomy? Yes, the ticky flow. This is the treatment in cerebral infarction. What is class 1 indication? Class 1 indication, you have to achieve a ticky 2B or ticky 3 flow. If you are unable to achieve, you have to continue and repeat the passes. Okay, so this is the ticky flow. You can see. And what are the blood pressure target if you have done successful intervention? If you have done complete recanalization, and you should control your blood pressure less than 140, because if you will not control, the chances of reperfusion injury is very high and the hemorrhagic transformation is also very high. If there is a partial recanalization TICI less than 2B, then your blood pressure should be less than 160 or 180. If there is no recanalization, you can keep your blood pressure high to keep patent the collateral vessels. So I will show you some cases. These all cases have been done in the NICVD and with the permission of the patient. This is the angiogram. You can see there the total occlusion of the M1 segment on the right side. You can see the straight segment, saphenous part, cavernous part, and the intracerebral part of the internal carotid artery. The MCA was totally occluded. We did a wire. Just you can see in tortuous vessel, you have a very difficult to cross the wire because of the tortuosity. So you have to take a support with the microcatheter. So with the help of microcatheter and distal access catheter, we advance the wire from this area. And after advancing the wire, we just have to remove the wire and give check injection, either we are in the vessel or not. If check injection, so now, and through the microcatheter, we just advance our stent retrieval and place the stent here. You can see the stent is placed here in the M1 segment, and with the help of stent, we just push our distal access catheter toward the thrombus side so that we just complete our Solumbra technique. And in this view, we can also assess the length of the stent by giving injection through this distal access catheter. This is the thrombus present, and the thrombus is just, we stent have just opened the artery. You can see clearly in between there the thrombus is seen. So after doing Solumbra technique in this patient, you can see the result, final result. There's a good TICI 3 flow seen in this patient. This is the epicranial AP view, and this is the lateral view in this patient. So another case which we have done, first of all, you have to do the common carotid shot to see the bifurcation, any lesion. And this is the M1 segment totally occluded on the left side. Again, wire is crossed over the wire. This is the distal aspiration catheter. It was crossed, thrombus was aspirated. This is the final result. You can see the TICI 3 flow in this case. So this is the adopt technique without using stent retrieval. So I just want to quickly show you the few cases that we have done in the NICVD. This was the 21-year-old young male. He was working in a fish shop. He had a history of AVR because of the aortic regurgitation. 3 years back, he was on warfarin. Suddenly, he developed weakness on the left side from last 2 hours. He presented in the hospital within 2 hours of the history. We did CT scan was normal. This is the CT angio. CT angio, you can see there the total occlusion of the M1 segment. So we just check. In this CT angio, the M1 segment was totally occluded on the right side, and we just have a look on the prosthetic valve that was open. There was no thrombus. The M1 segment was occluded. We did his adopt and achieve the TICI 3 flow. You can see the patient, while this video was the permission of the patient. So he was examined in the emergency department. He was unable to move his left side of the body. Then after doing mechanical thrombectomy, patient regained his power by 5/5 immediately after 3 hours of the procedure. So another case, this patient was again 23-year-old young boy. He has a history of anterior wall MI. He was presented in the emergency of NICVD, and a primary PCR was done, and primary PCR to LAD was done. And during discharge, echo showed there was a thrombus in the LV. So patient developed weakness on the right side of the body within 3 hours. Luckily, patient reached in hospital at time. This is the angiogram shows the occlusion of the left MCA. This is the volumetric image. You can see there is a cutout point. There is the occlusion of the MCA, and we did the aspiration and we achieved the flow. This patient was examined in the CT department while he was unable to move the left side of body. After that, you can see patient was all right after 8-10 hours. So this is another patient. He was assessed in the CT department. He was unable to move. It's the left side of the body. His the angiogram was shows. The total occlusion of the right MCA, and we just do the adopt technique. Thrombus was aspirated. This patient have developed dramatic response. He regained his power immediately within 30 minutes of the procedure. We examined this patient in the cath lab. While after doing the mechanical thrombectomy, he was able to move his left side of the body. Thank you. And I want to show you this case. He was a 52-year-old male hypertensive. He presented with the left side weakness and slurred speech from 4 hours. The NIH score was 10, CT scan was normal, but CT angio shows there's an occlusion of the right internal carotid artery. So he is a type 2R. We have a quite difficulty to engage the ICA. So finally, we did his angiogram that shows there's a totally occlusion of the internal carotid artery from its terminus portion. So first of all, I did is aspiration in the ICA. This is distal expiration catheter. Just aspirate the thrombus in the ICA. After doing aspiration, you can see the ICA is open, but there's a thrombus seen in the M1 portion, M1 segment of the MCA. So again the wire was crossed, the check injection was given, and the aspiration was done in the M1 segment. But you can see is a ticky 2B flow, but there was a thrombus present in the M1 segment. So we have stopped here, give some vasodilator, and again we'll again done the solumbra. In this case, I just crossed the wire and put a stent, and just put a stent over here, and just grab the rest of the thrombus, and now you can see the final result. Also, there was thrombus; it was clear mostly. And this patient also have a very good response immediately after 10 hours. You can see. And there are other cases, a few cases which we have done. And this old lady, she present with the occlusion of the M1 segment, right MCA. It was open. She was doing fine after the procedure. So I want to show you this data. Up to now, from 1 year ST, we have done 85 mechanical thrombectomies, and in which, along with 11 TPA, those patients who were present with a small vessel occlusion. Alhamdulillah, we have a very good result. Initially, we have some hiccups in the initial phase of our time. Later on, from the next half, we are doing. We have seen a very good response in our patients. So NICVD, Alhamdulillah, is giving 24/7 stroke service to all patients throughout the country. We are services to everyone is totally free of cost, and we are stroke team. We are very thankful to the Professor Nadeem Kamar that he initiated this program for free of cost for everyone here in the NICVD. We have a more than 50% functional independence rate in our cases minimum. So from 2015, mechanical thrombectomy is the treatment of choice in large vessel occlusion and acute stroke. And you can see the centers where they are performing mechanical thrombectomy. These are the centers. But training of new intervention neurologist, he may need more than 2 to 3 years for doing acute stroke intervention. But the training of experienced intervention cardiologists, they need only 2 to 3 months. So the cardiologists are involving in this. In the last, I thank you to all.